Hello, everybody, and welcome to this week's Telehealth Secrets or VSee Academy webinar. We have, I'm Anne, and I'll be just giving some quick housekeeping announcements. Becky is our moderator today, and Dr. Edward Kafterian will be our speaker. So just a few quick things. Can I get a quick show of hands if you can hear me okay and see the screen? All right, great, fantastic. Okay, so this session will be recorded and we'll be sending the video and the slides out in the next few days. Please submit your questions as you think of them during the chat. We'll have a Q&A, a nice long Q&A session where you can ask all your questions, and we'll do our best to get to all your questions today. And I also want to let you know that we have a special Telehealth Secrets webinar tomorrow as well on VA telehealth and COVID-19. And then we have another webinar on getting started with online counseling June 11th with Roy Huggins. And you can find these at vsee.com webinars. So with that, I'm going to go ahead and pass the time over to Becky.
All right, great. Thanks, Anne. Okay, first of all, I would like to say that, Dr. Kafterian, this is such an honor to have you here with us today. And everyone, welcome to this week's Telehealth Secret. My name is Becky Wei, and I'm the VP of Sales at VSee. If you are not familiar with VSee, VSee is the platform for telehealth platform for MD Live, DaVita, and NASA on the space station. And today, I'm so excited to welcome back Dr. Ed Kafterian as our guest for this week. And for those who don't know, Dr. Kafterian is an internationally recognized expert in telepsychiatry, and he is the vice chairman of mental health for the American Telemedicine Association, and he's also the co-author of the APA and ATA's best practices in video conferencing-based telemental health. And previously, he served as the chief of telepsychiatry for the entire state of California's correctional facilities, where he built and managed the most extensive prison telepsychiatry program in the world. And he's talked about that work in the previous Telehealth Secrets program, which you can definitely check out, and we'll give you that link in the chat. And Dr. Kafterian is also the chairman and CEO of Orbit Health, a national leader in telepsychiatry services. But something you might not know about Dr. Kafterian is that he loves skiing. And he got a chance to live in Colorado for a year where he taught children's ski school. It's very cool. He also loves sushi and dim sum, and he is always looking for ways to combine all three loves. And thank you so much again, Dr. Kafterian, for joining us today. We are so excited to learn your best practices and tips, for getting started in your own telepsych practice. So please take it away.
Thank you so much. It's really an honor to be here. And if I was not married, that would be a good thing to put on Match.com, right? That I like skiing.
Yes, it's a wonderful profile.
So I wanted to ask you, is everything looking okay as far as the screen and the PowerPoint?
Yes.
Yes, okay, so we can get started?
Yes.
Okay, it's not cut off or anything? Okay, good. So look, we're going to do a real quick review of some important things to keep in mind when you're starting your telepsychiatry practice. We're going to go for about 15 minutes. We're going to keep it really high level. Okay, so I do want to say disclosure is that I'm the chairman and CEO of Orbit Health Telepsychiatry. So it's a company that provides telepsychiatry services. So that's the main disclosure that I want to make. I also want to say that this is an attempt to provide useful information, and I think you're going to learn a lot from this. But I also want to say that it's important that we don't consider this legal advice and that you seek an attorney for anything that requires telehealth rules and regulations. So I want to use a term that I believe Milton Chen has used in VSee. Called the digital health gold rush. I think that these days everybody wants to get into telehealth, so it's a massive gold rush, and with that there's some adventures. Okay, So the adventures of telepsychiatry. Everybody wants to get involved, but we might not always be aware of what we're getting into, and perhaps I can help kind of enlighten people about what they might expect to see. So the first tip that I would say is to be aware of the legal and regulatory landscape. Now, that's really important. It's always been important, and it's important now, even with COVID. Now, prior to practicing telepsychiatry, there are certain things you want to keep in mind with regard to the rules and regulations. You want to check with your local, state, and federal laws, because all the jurisdictions can have special rules around telehealth and telepsychiatry. Now, certain things like apps and other healthcare devices that may be used in mental health and telepsychiatry, they may be regulated by they fall under the jurisdiction of the FDA, the FCC, perhaps the DEA, and so you want to be aware of that, and you want to check with your licensing board to make sure that they don't have special rules around telepsychiatry. I know in California they do make a reference to telemedicine. So you want to be sure that you're aware of what the licensing board has to say about it. You want to consult with an attorney, of course, and you want to check with your malpractice carrier, because you don't want to assume automatically that you're going to be covered for a telehealth encounter. You might have to have a rider in your policy. You might have to have a special telehealth policy. Some insurance companies cover it, some don't. Now, what I want to say is that this really colorful display here is my attempt to show how far we've come and how far we need to go. So the current practice, has evolved beyond what the current legislation has evolved to. So the practice of telepsychiatry is way ahead of the regulatory bodies, okay? And they're catching up right now, and especially with COVID, they're catching up a little bit. But telepsychiatry is not really the future. Telepsychiatry is the past, really. So we're all trying to get caught up to what we should have been doing the last couple of decades. And the future is going to be really exciting. And we don't have time to talk about all the fancy ways that telehealth and telepsychiatry is going to change for the future. Perhaps on a different talk, we can get into that. So in the era of COVID-19, there has been some loosening of the restrictions, or probably a better way to say it is the enforcement of the rules and regulations. Now, a lot of people consider this now, okay, it's just open season, you can do whatever you want, but that's not advisable, because I think it's really important that you understand that a lot of these rules, probably most of these rules, are still in place. It's just the enforcement of the rules are sort of now discretionary, meaning that these regulatory bodies decide not to enforce certain rules. For example, HIPAA penalties, as long as you're acting in good faith, they have discretion to not penalize you for HIPAA breaches. But I don't think that that's a good way to approach telehealth. I think that you need to approach it in a way where you're protecting the confidentiality and the privacy as much as you possibly can, and consider what you do in the context of what's going to happen when COVID goes away, because you want to set yourself up in a way that does not hamstring you when the public health emergency goes away. So with the public health emergency declaration, you have 49 states with waivers, and you can go to the Federation of State Medical Boards to see how your state approaches COVID-19. And there's some degree of reciprocity in many of the states. So in many of the states, even if you don't have a license to practice medicine in that state, some states will allow you to practice medicine during the public health emergency, but you want to be very careful about doing it the way that the state medical boards have determined is acceptable. And the degree of the waiver varies, and some states don't really have much of a waiver. They say that they do, but they don't. So you want to go to the FSMB and look at that. You want to also be aware of the Interstate Medical Licensure Compact, which allows you to get a state license faster in a different state, as long as your state participates in the Interstate Medical Licensure Compact. There's also the FCVS, which allows you to put your information into a database, and then that makes your information more portable in case you want to apply for a license in a state that participates in the FCVS. Telehealth commercial parity laws, they have changed over time, and there's a difference between whether they offer true parity, like payment parity, versus just they allow telehealth to be reimbursed. Now, with COVID-19 especially, a lot of the commercial health plans, they're going above and beyond what the floor is, what the state is saying is the bare minimum. And a lot of these commercial health plans are paying an equal amount for telehealth encounters as on-site. Now, the coverage varies by the policy. Half of the states cover for store and, or half of the parity laws cover store and forward. So you need to be aware of that. So store and forward being a separate way of doing medicine, where you capture the information, you store it, and then you review it at a different time. That definitely, there's some variability in how the states are handling that. So in the era of COVID-19, CMS, the Centers for Medicaid and Medicare, they have actually been great, and they're expanding the eligible services. They're adding a lot of codes. They're paying a lot of the services the same rate as in person. Most importantly, they're lifting the geographic restrictions. So it used to be that you need to practice in a rural rural area or health professional shortage area in order to do a telehealth for CMS. They've lifted that restriction, at least for the public health emergency, and they've allowed more than just the healthcare professionals that they had designated in the past to provide telehealth. So that pertains to telepsychiatry in the sense that, you know, more types of professionals can help support the efforts of a telepsychiatrist as well. So we're not going to get too far into the CMS. That's a whole other conversation, but here are some points that you can look at. And I highly recommend that you go to the CMS website if you do have a CMS population that you want to serve. So with consents, that can vary per state. I know in some states you have no requirement for a special consent for telepsychiatry. In some states like California, you have the requirement to do a verbal consent, and I always recommend that you document that consent in the chart just to keep yourself safe, even if a written consent is not required. So some states don't require consent, some states require a full consent written, and others require, like California, require a verbal consent. And some states like California have waived temporarily some of the verbiage around the consents. So that's something to consider as well. Now, getting into the Ryan-Haight Act, a lot of you may have heard of this. This is a boy who prescribed medication, Vicodin, over the internet without having seen a doctor, and therefore died of an overdose. And therefore, the government established the Ryan-Haight Act, which only allows you to prescribe a controlled substance with a valid prescription, and valid means in person unless you meet a telehealth exception. And these are the 7 exceptions to the in-person requirement. So meaning that if you meet one of these exceptions, you can prescribe controlled substances via telehealth. And as you see, I've highlighted the public health emergency, which is an exception, which means that it allows us to prescribe controlled substances in a public health emergency without having an in-person exam. Again, you want to consult with an attorney, but generally during this COVID crisis, you can prescribe the controlled substance via telehealth, but it does have to be for a legitimate medical purpose. So Telehealth. Oh, and let's go back to that. There are some other exceptions that you want to be aware of, and we can read them out for you. The DEA serving a DEA registered hospital clinic is probably the one that is most relevant to most practices. As you can see, there is a special registration exception, meaning that if you register as a practitioner doing telehealth, then you meet the exception. The problem is that the DEA has not actually established a special registration process. So it's sort of funny because they say you can do this, but then they don't give any mechanism to do it. And in fact, Congress has mandated that they come up with this special registration process. And DEA was supposed to do it by October of 2019, so they're kind of behind in the times here. So hopefully we'll get a special registration process. We've have heard word that that's happening, but we don't know exactly when it's going to happen, when the DEA is going to make that happen. So we are now in a public health emergency, and like I said, you can use live video to do telehealth as long as it's for a legitimate medical purpose, such as psychiatry, and that you're acting in accordance with the state and federal law. So it's really important that you look at your jurisdictions as well. And I want to say that another thing to keep in mind is that this is from the DEA. The practitioners may prescribe controlled substances. They may prescribe buprenorphine to new and existing patients via telephone without requiring the practitioner to first conduct an exam via telemedicine. So this is really remarkable language. And I don't know, you have to still be very careful if you're going to do buprenorphine treatment over the telephone without having done an exam. It's a bit risky legally, but I think that the DEA has carved out a path for that. Keep in mind that you still have to meet the qualifications of SAMHSA to be a so-called data waived practitioner, so that you prescribe these detox and addiction medications, because you can't do it without a data waiver. Number 2 tip. So implementing standard protocols is important, and the first of which would be establish roles and responsibilities. So if you're working with a clinic on the other side, or even a patient in their home on the other side, you want to establish when you're going to do the coverage. You want to establish the mode of communication. If you want to set up appointments, if you want to follow up on things, you want to make sure that everyone understands how that communication is going to happen, because you don't want the patient to be calling you on the telephone if you've established that the communication needs to be done via video. Now, you can talk to the patient over the telephone, but you want to be careful, because that's not considered a telemedicine encounter. Now, with the COVID-19, there is some flexibility there, but again, I highly recommend that you do the bulk of your patient sessions on video. Live video synchronous, when you can hear and see the patient. You can coordinate some of the other things on the telephone with no issues, really, or few issues. You want to make sure that you identify the patient. So especially if they're in their homes, you want to make sure that you're talking to the right patient. It's helpful if you have the patient show you their ID if you're not working within a facility and you're working with the patient directly in their homes. And you really I don't know that you need to do that every single time, but you want to make sure that you get the right patient every time. And you also want to make sure that you're coordinating with the people that are on site regularly. You want to manage emergencies in a proper way. So, of course, with telepsychiatry, we can have emergencies that have to do with grave disability. We can have danger to self, danger to others. So you want to make sure to monitor the patient's affect, make sure that the patient is not getting out of control. You want to end the session if you feel that you're agitating the patient, and just use your clinical reasoning, the best judgment, and that's really up to you as a provider to decide when the session is no longer is helpful, and perhaps even stirring the patient up a little too much. Ideally, you want to have a patient support person, whether that's the telepresenter on the clinic side or somebody like a family member or a confidant on the other, in the patient's home or around the patient. that the patient has given you permission to work with them on all of this. So if the patient becomes agitated or dangerous to themselves or others, you have the number of a patient support person that you can talk to that can help you manage that emergency. And send the patient, call 911, that kind of thing. You want to make sure that the patient's location is known to you. You don't want to, not only to comply with state and federal law and jurisdictional law, but you also want to have an idea of what they're exposed to, what their environment is like, and you want to know if they're on the move, if they're outside of the house. It's really important clinically and even legally to know where your patient is. You want to know where the closest ER is so that you can send the patient to the ER if necessary. And then again, you want to be able to coordinate regularly with the people that are involved in the patient's care. Tip number 3, you want to choose and manage the right technology. And, I would say that, and this is from the VSee website, they have some great access to some equipment, and there's all kinds of telehealth equipment. Now with telepsychiatry, all you really need is audio and video, good quality, clear audio and video. So you want a speakerphone and a webcam that are high quality. You don't want to use your laptop camera unless you have a really sophisticated laptop that has high pixels. You want to use a plug and play. You plug it into the USB port and you have a high quality camera right there. Same thing with the speaker microphone. You might be able to get away with the speaker, the real tech that's on your computer, or the speaker that's on your computer, but it might give kind of a canned sound to it. So I like to use a separate microphone speaker and not endorsing any specific products, but these are a couple of those. Now with the bandwidth, you want to make sure that you have strong bandwidth, and that can be variable. I mean, the bare minimum is 3 megs up and down, meaning download speed and upload speed 3 megs per second. That's very low though. I mean, I wouldn't really recommend that. I would recommend a bandwidth of an upload speed of 10 and a download speed of you can easily get to 50, 50 to 200 for some commercial packages, but you want to make sure that you have dedicated bandwidth. So when you talk with your Spectrum or AT&T or whoever you use, you want to make sure that you have dedicated bandwidth, because now if you're sharing your bandwidth, you're sharing with everybody in your neighborhood, the kids that are at home from school, that kind of thing. And the bandwidth can go up and down, but dedicated bandwidth allows you to have dedicated bandwidth. So you want to protect your session, and these are all things that you can review in terms of security features. VSee has these, not promoting any particular video conferencing, but just saying that VSee does have this 256-bit encryption, and you want to make sure that you have a padlock icon on your desktop to show that the session is secure. And some video conferencing providers include audio signatures, so that if the session is shared, then you can identify who shared the session by the audio signature, who recorded the session by the audio signature. You want to disable the recording of the meeting unless there is a reason to record, and like store and forward. And you want to be aware of people interrupting your session. So you want to make sure to ask your provider if there are ways that you can create passwords, you can have waiting rooms and whatnot. So these are all things that VSee provides, but again, other services provide that as well. So it's up to you. Now, consider clinical factors. So as a psychiatrist, I'm obviously very in tune to clinically what matters in a telehealth appointment. There are no absolute contraindications to telepsychiatry. So if a patient has paranoid schizophrenia or major depression, there's no absolute contraindication, but you need to be aware of if telehealth is working for that patient, if it makes sense for that patient's circumstances. You want to make sure that you assess the risk. You want to make sure that you observe the patient's cognitive function to make sure that they understand what's happening, and especially around consent. You want to make sure that you understand the medical aspects of the care. For example, if you see somebody that's jaundiced on camera and you're not aware of their medical history, you need to be aware if they have like liver failure. So, other signs, other medical aspects of care need to be managed. You want to make sure that you take into account the severity of the condition. So if the patient is actively, acutely suicidal, perhaps seeing them in their homes is not appropriate. Of course, it's case by case, but generally speaking, if they're a danger to themselves or others, they don't belong at home. They belong in the emergency department for a 5150 evaluation. And then, of course, boundaries of communication. Like I said before, you want to make sure that you have that discussion with the patient about when you want the patient to talk with you and how they want to communicate urgent needs to you. Okay. Tip number 5 is real simple. There are lots of online resources. One of the great ones is the Telehealth Resource Center. I don't have any affiliation with that, but I've used it in the past. Each region of the country has a Telehealth Resource Center. California has a really good one, and it's called the California Telehealth Resource Center. There's also the Center for Connected Health Policy. There is the American Medical Association, which is really helpful right now for COVID rules around Medicare. The APA has a toolkit as well. The American Psychiatric Association has a really helpful telepsychiatry toolkit. I'm on the committee with the APA telepsychiatry, so I'm aware of that and have helped put that together, and I can tell you it's a great tool. You also can look at our website, Orbit Health, if you'd like to, and it connects you to a bunch of different resources. So that being said, I'm available to take questions.
Great. Thank you so much, Dr. Kaptarian. This is very, helpful information, and you make your presentation very fun and interesting. Thank you.
Thank you.
All right.
It can be a dry topic, but hopefully you're getting something out of it, and it's an exciting time to be in telehealth. So happy to do this.
Yeah, I enjoyed your presentation a lot.
Thank you.
All right, let's get to the question. I have the first question. So, how difficult it is to get the interstate licensure?
Yeah, so it's a process. You contact their website, the Interstate Medical Licensure Compact website, and you can Google it, or the IMLC, whatever the acronym is, and they walk you through it. It's not super difficult. It does take a little bit of time to establish your account there, but then once you do, you can get a state license for like a reciprocal state license. And that's probably not the right term for it. You can add a license to a state that is involved in that compact within about two weeks or so. So it doesn't take a whole lot of time, but you do need to establish yourself within the compact.
Okay, all right, thank you. Okay, the next question is, what are some of the barriers to the wider adoption of the telepsychiatry?
Yeah, so it's really interesting because even now after COVID, after it's proven that we need telehealth, there are administrators and policymakers that are still dragging their heels. Fortunately, the one silver lining of COVID is that it accelerated the growth of telehealth and telepsychiatry like 100-fold. And so CMS is really the leader for everything in medicine in terms of like what's billable and what's not. And because CMS has moved forward aggressively to allow telehealth, I think we've crossed the Rubicon, so to speak. So meaning that it's going to be really hard for people to go back to the old rules. And as we can see, telehealth is a safety net. And some of the barriers to further adoption of that safety net are just, this idea that you have to be in the same room and feel the energy of the patient and all of that. I mean, there is some merit to being in the same room as the patient, but I think that we need to also understand that sometimes patients don't have any options, and it's better to do telehealth than nothing at all. In fact, there are some advantages to telehealth over on-site health as well. So barriers would be just the overall thinking of policymakers, administrators. The technology is not a barrier. So the technology is fully capable now of doing really great telehealth sessions. You can have, I guess, the barrier for a physical examination. You would have to, do a guided examination, meaning that that anything that you want done remotely, you have to have the patient do it for you or have somebody on site do it for you. And so that can be a limitation. And yeah, so that's about it.
Okay, right. Because you mentioned about the technology is not a barrier. So on the related topic, what technology trends should mental health and addiction be anticipating in the next few years, like like robots, AI, remote monitoring?
Yeah, so some real Black Mirror stuff, right? No, it's
Yes.
it's funny because the movies really do inform us about what our imaginations can bring to the world. With COVID, it was predicted before it happened in the movies, and the movies predict, artificial intelligence and whatnot. Machine learning, artificial intelligence, those are gonna definitely have a big impact. We have chatbots right now that are learning how to communicate like human beings, and eventually they're going to pass the so-called Turing test. So the Turing test is if you're talking to a machine and you don't know that it's a machine, you think it's a computer, then the machine, you think that it's a human being. Then if that's the case, that computer or that machine has passed the Turing test. It's basically fooled you. And I believe that at least in written communication and probably audio communication, I would say almost without doubt, it's going to pass the Turing test, and we're not going to know if we're talking to a computer or a human being. And then with the picture, the video, it's going to be a while, maybe not in our lifetimes, but the video is also going to fool us, and we're not going to know if we're talking to a human or a computer. Now that can be really scary and maybe even dangerous if we don't utilize the technology the right way. But I think that we've never been we've never not done technology because of fear. And I think that it's inevitable. Somebody's going to do it, so we might as well control it, and we might as well direct it in a way that serves human beings. So the future has chatbots in it. It has artificial intelligence, artificial general intelligence, which means artificial intelligence that has learned how to learn. Right now, it just learns what we teach it. But if it learns how to learn, then we're going to enter a whole new era of patient care.
Right, great, thank you. Okay, so we're gonna switch to a little bit different topic for questions. So I have related questions about, like patient, like how do you make a patient feel more comfortable? And then, what are the acceptance rate? Like how do you adjust this technology to patients so that, they will feel more comfortable?
Yeah, that's actually a really great question. So, and it may be generational as well, because the millennials and younger generations they grew up with technology and they're technology natives, whereas elderly people were not technology, they didn't grow up with this kind of technology. And so there can be a difference, although elderly people do like telepsychiatry a lot as well. So you want to first be aware of any cultural or generational issues. Cultural issues across the board need to be considered. So regardless of whether you're on site or with telehealth, you need, if you're speaking to a Spanish speaker or another language speaker, you want to have good translation. You want to be aware of the mental health issues, how they manifest themselves in other cultures. So you want to be aware of those general cultural issues. You also want to be, you want to come across professionally. So you want to look like you would want your doctor to look. So I have in my background, I have diplomas, and I'm trying to dress professionally, right? And so you want to come across in a way where you feel comfortable with the patient feels comfortable with you, and you project a professional demeanor. Now, you want to, when getting consent from the patient, it's helpful to explain to them that this is the technology that you're using is of a certain security level. I mean, we use top level security like VSee, but a lot of technologies have that 256 encryption, and you want to make sure that you express to the patient that the session is secure. Now, of course, there's always a chance that the session could become unsecure, and you want to explain that to them too. But you want to highlight the fact that everything that you can do via telehealth in this encounter, everything that you want to be doing on site, or most of everything you want to be doing on site, you can do via telehealth, and that you'll take good care of the patient. If the patient really doesn't want to do telehealth, then you ought to work with the facility or the patient to decide the best way to do it. And then one really important thing, I'll end on this point, which is you want to say, even if they have reservations, you say, look, you have the right to refuse, but give it a try. Let's give it a try, a couple sessions, see how you like it. And inevitably, for my sessions, it's never been an issue. Even with the ones that were a little bit hesitant, they later said, you know what, this is really great. And they don't even often want to go back to the regular way of doing things.
Okay, right, thank you. And then the next question is, what are the best practices to consider when suspecting that the patient is in a situation of abuse or violence, and how to make an initial assessment through telepsychiatry?
And what was the second part of that question?
How to make an initial assessment through telepsychiatry.
Initial assessment of the dangers to the patient, or in general?
I think the question, yeah, let me repeat that.
Okay.
So when you suspect the patient is in a situation of abuse or violence. Yeah.
Okay, gotcha. So of course, there's the protective services that you would need to call if the patient is a dependent, like an elderly, any sort of, like either a disabled elderly, a child, somebody who's in the care and dependency of another person. You want to be able to report that to protective services, and the rules of that depend on your state, and the thresholds for that. But and you want to be careful about that too. You don't want to falsely report something. It's helpful to get a second opinion from a trusted colleague. Again, you want to be respectful of the patient confidentiality, so you can talk in general terms about the situation. You can also arrange for the patient to be seen privately. And I would recommend, in that situation, I would recommend seeing that patient in a clinic or office setting to determine whether what you saw on camera and what you're learning about the patient may rise to the level of abuse. So, I mean, it's a lot of it is just common sense, but of course, you want to protect your patient, and there's no reason why you can't protect your patient via telehealth. I mean, you still have a phone, you still have an ability to coordinate with people, and none of that has to change.
Okay, thank you. Right, another question is, how do you get the dedicated bandwidth?
Oh, that's a great question. So, and I'm sorry if I wasn't clear about that earlier. You just ask the service provider, like I said, I can think of Spectrum and AT&T, and there are tons of others, but you ask them directly that you want the package that has dedicated bandwidth. So it's oftentimes, $10, $20 more, but it's well worth it because you don't have that swinging of up. You can predict what your bandwidth is. You don't have to worry that when school lets out, your bandwidth is going to drop, especially now that school is inside everyone's homes.
Yeah, that's right. Okay, I just want to add one more tip to that question. So, if you are using a lot of video conferencing software, like Skype or Facebook Messenger, you might want to close that out as well, because like those applications may use the bandwidth in the background. So if you close those applications, then you have more available bandwidth.
That's a great point, and I want to add to that and say that oftentimes we're using electronic health records that soak up bandwidth. So the bandwidth requirements for a basic video counter are very low. but as you said, they these other applications, they suck up the bandwidth.
Mm-hmm.
So you can run an EHR and see the patient and check your labs and your emails and all of that all on one screen. You can do that. You just want to make sure that you're not running unnecessary programs and your bandwidth can handle it. And if, like I said, if you get a bandwidth of 10 megs upload and 50 to 100, 50 is plenty, you can run quite a few programs without having problems. Now, if you, and one of the things I don't intend to plug VSee so much, but I do want to point out that VSee does deal with low bandwidth issues. They have a unique way of dealing with it, which may be different than other providers. But basically, what happens if your bandwidth is stressed, you get pixelation, you get video delays and other problems that can really interfere with the patient session. And that is like death for the profession of telepsychiatry, to have bad video, because the patient's turned off by it, the doctors hate it, it's just not good. So I would say that make sure to protect your bandwidth.
All right, thank you. Okay, so the next question is, how are patients responding to this method of care?
Yeah, good question. So, patients, the vast majority, they respond really, really well. And I'm assuming the question has to do with outcomes, because we talked already about how they feel about telepsychiatry and when they first start, any reservations they may have and whatnot. So we talked about that. But as far as outcomes, gosh, it's been great. I mean, we've had really great outcomes. The research on it needs to continue. If we're going to get a clear answer on how the outcomes differ, but I'm not actually thinking that it's going to make a big difference to do a lot of research on this, because telepsychiatry is just a way to deliver care. It's not a different type of care. It's not like it's Zoloft instead of Prozac, on-site versus video. It's not that. It's not a different treatment. It's just a different modality. So you're giving the same treatment. You're just doing it via video. And do we really need to study that, the outcomes? I'm not convinced that we do. I think it's pretty much common sense and inevitable. But for anybody who wants to pull back on telepsychiatry and say we can unring that bell, then I suppose they can do a lot of research on it. But the way that you talk to your patient, the way that you assess, diagnose, and treat your patient, that all is the same, or largely the same. And so it's not different care, it's just care delivered differently.
I see. Okay, right. Next question is, do you recommend using a certain number of screens for telepsychiatry setup?
You know what, that's a great question. I'm gonna give you a tip that is super valuable. I use a 49-inch a widescreen monitor, okay? And I would show you, but you can look it up yourself. I don't want to disturb the camera and show you what the screen looks like, but it's a huge monitor and it's expensive. It's like $1,000, a little bit more than $1,000, but it's worth it because you can have everything on the same screen. And did I answer the question? I lost track of the question.
Yeah, it's asking about the number of screens.
Oh, the number of screens, right.
Yeah, I think like bigger screen, one screen is better too. Yeah.
Yeah, one screen's better, but I got so excited about this fancy monitor that I have that I forgot to answer the actual question, which is, if you don't want to spend the $1,000 for that huge monitor, I do recommend multiple screens in order for you to put up, different aspects. Like you can put on one screen the patient's face, you can put another screen the medical record, you can put another screen your emails. It's a little bit trickier to toggle between screens sometimes, but you can do your settings in your computer so that it's flush, so that all your screens are together, and then your mouse can drag along just cleanly across the screen. But, and that's better than trying to cram everything into a laptop screen, like a tiny little laptop screen that can feel claustrophobic. But the best way to do it is one big screen. So I would say that's like the biggest tip of the day right there.
Yes, I like your idea, like, one big screen that's less like, troublesome.
Yeah, I mean, if you want to do serious telepsychiatry and you want to make it a permanent part of your practice, spend $1,000, get that huge screen, and you'll be happy. And there are different manufacturers. I'm not going to promote any specific one, but there are different ones.
Yes. Okay. All right. Next, how to talk to clients to find a place to be seen for telehealth to protect confidentiality when people are around their home.
Yeah, that's a good one. So I would extend that to providers as well, how to find a place, because where we all have to deal with this new reality of COVID, and a lot of families are now not leaving the house. So that can interrupt from both sides. Probably the best way to do this is to have 2 doors between you and the rest of the family or rest of the interruptions. And that can go for you as the provider or the patient as well. So if there's a room that is 2 doors away, then if a child comes and knocks on the door, they're knocking on that first door and they can't get to that second door. And in fact, I've installed a second door basically in a hallway. So there was a hallway, and I installed a door on both sides of the hallway so that there's definitely a buffer. Now with the patient, you want to be very careful about this and make sure that you ask the patient and the patient advocate to find a confidential space. Ideally you want 4 walls and a door, okay? So you don't want to have the patient do this in a gazebo, or some other place where anybody can walk in. You want it to be a place where there's not a lot of street noise, so maybe somewhere a little bit closer inside than right out on the street. And you want to make sure that when the session is going, the patient knows to tell their family members they're having the session now, or tell them that they don't have to get into what that medically sensitive things, but to basically make sure that their family is somewhere contained and not able to really interfere with the session, unless the family is integrated into the therapy, like family therapy, or you want to be able to talk with family members for certain things.
Okay, that's very helpful. Thank you.
You're welcome.
All right. Next question is, have you had any issues with getting reimbursed for telemedicine sessions? Any tips to be aware of when working with private payers or Medicaid?
Yeah, so the first thing that you want to do is you want to make sure that you're coding the right way, that the first thing is you want to talk with the insurance company and make sure that they're covering it. You want to have an agreement of how the payment's going to be made if the insurance doesn't cover it. And maybe in some cases, private practice, a patient may have to pay out of pocket at certain times, but for most people who go through insurance who can't afford to pay out of pocket, you need to make sure that you understand the commercial rules about the billing. You want to make sure you understand the CMS rules. You want to make sure you're registered with CMS so that you can bill CMS. You want to make sure that the codes that you're using are appropriate codes for the account encounters. And some people, they're new to this and they're new to this coding process. You want to be careful not to incorrectly code, because even if your heart is in the right place and you're operating in good faith, some of these regulatory bodies can be quite unforgiving when it comes to coding the wrong way. And so, it's a constant challenge to make sure that you're coding the right way. I have not had a lot of issues getting reimbursed, but these are some things that you need to keep in mind to make sure that you do it upfront so that you're not chasing after the payment later. If you're working within a private practice, you might be able to, well, you can have a system like similar to PayPal, where the patient can pay upfront, sort of like as a retainer, and then you can draw from that, or you can have a credit card payment, that kind of thing. Not to get too detailed here, but like if you use a credit card, then you have to pay the 3% or whatever on top of that. So there are all kinds of issues that you have to sort through, but generally getting all those ducks in a row ahead of time is better than doing it and then figuring out how to get it reimbursed later.
I see. Great. Yeah, related to the Medicare coding, we just did a webinar last week. So if you are interested in, please definitely check it out on vsee.com/webinars. Right?
Absolutely, yeah. And CMS does have different types of visits. There's like the e-visit, the virtual check-in, and then the classic Medicare telehealth visit. So, and each of them have certain rules, and there's some certain waivers around them. So I definitely recommend that you check out the other webinars that talk about the billing and CMS.
Right. Okay, moving on. Right. Are there any behavioral health conditions that cannot be treated through telepsychiatry?
Yes, so as I reviewed in the PowerPoint, there is no absolute contraindication to it. Like I use the example of paranoid schizophrenia. Like if somebody has paranoid schizophrenia, some people might think, oh gosh, I can't do telehealth because they're going to get paranoid. Now, the incidence of that is pretty low. I can count on less than one hand the number of times somebody was paranoid about the actual video, like being recorded or not recorded, whatnot. And that was usually something that we could easily address by explaining the security features, that we're not recording this and that. And so it's not been an issue. But yeah, there's no absolute contraindication. But as I said before, if it's not working for the patient, if they just don't like it and they're uncomfortable and they're not sharing and their resistance goes beyond that initial reluctance or hesitancy of doing it, you want to find another way. Like I said, that's pretty rare. It's pretty rare for you to have a patient refuse or it to not work for whatever reason. But generally speaking, you want to, again, make sure that you understand the risks, like if they're a high suicide risk, you want to be a little more careful about that. Somebody who's had suicide attempts, they can still be seen via telehealth. But if they're actively suicidal or if they're super high risk and you're just, you don't have any mechanisms in place to take care of them if they go off the rails, you may want to, I'm not saying you can not do telehealth, but you got to be a little more careful about telehealth.
I see. Okay, great, thanks. So we are getting down to the end of our time together. We had a lot of great questions. So, we apologize if we cannot get to all of your questions. So before we wrap up, I would like to ask you a closing question. So do you think COVID-19 can make a permanent change in how we do psychiatry or, healthcare in general? Like, what would you want that to look like?
Yeah, the answer is yes. It has already changed healthcare, and this is substantial healthcare change in terms of how things are done. Lots of doctors all of a sudden have been exposed to doing business this way. Patients are starting to see what it's like. So the horse has left the barn, the bell has been rung, it can't be unrung. And I think that telehealth will continue to transform healthcare until the word telehealth is obsolete. At some point, it's going to be pointless to even use the term telehealth or telepsychiatry because it's all the technology is going to be blended into what we do. So it's not going to be a separate thing like, oh, I'm a telepsychiatrist or I'm a regular psychiatrist. It's going to be everybody's using technology in various forms. Yes. So I think that the future is very exciting. I'm really happy that we're part of it.
Mm-hmm. All right, great. Thank you so much. This is such an honor to have you here, Dr. Kaftavian.
It's an honor to be here. Thank you so much for having me.
All right. Yeah, until next time then. Thank you. Thank you everyone for joining in today too. All right. And do you have any reminders or any
No, we just have that one, we have that special telehealth, VA telehealth webinar tomorrow. And then I think that's the big one. So yeah, so thank you everybody for joining us, and please join us again next time.
All right. Stay safe, everyone. Thank you. Bye.
Bye-bye.